Your examination of the heart will consist of inspection, palpation, and auscultation. Let's begin with inspection and palpation.
I'm going to look at your chest.
To examine the heart, stand at the patient's right side. Have the patient remain supine with the upper body raised to about 30 degrees. First, inspect the anterior chest, noting any heaves or lifts. None are observed here. Careful inspection may also reveal the location of the apical impulse. When visible, the apical impulse is normally seen in the left fifth interspace at or medial to the midclavicular line. Later in the examination, you will palpate to more clearly identify the apical impulse. Following inspection, proceed with general palpation of the chest wall. First, palpate for impulses using your finger pads. Hold them flat or obliquely on the body surface as you palpate in the right and left second interspaces, along the left sternal border, and in the apical area. Ventricular impulses may heave or lift your fingers. Then check for thrills by pressing the ball of your hand firmly on the chest in these same locations. If subsequent auscultation reveals a loud murmur, go back and check for thrills over that area again. Next, identify the apical impulse. The apical impulse represents the brief early pulsation of the left ventricle as it moves anteriorly during contraction and touches the chest wall. Note that in most examinations, the apical impulse is the point of maximal impulse, or PMI. However, some pathologic conditions, an enlarged right ventricle, for example, may produce a pulsation that is more prominent than the apical impulse. Using the palmar surfaces of several fingers, then for finer assessments, your fingertips followed by one finger alone, palpate to confirm the characteristics of the apical impulse. You will note its location, diameter, and amplitude. Identify the location of the apical impulse by the interspaces in which you feel it, and by its distance in centimeters from the midsternal line. If you experience difficulty in locating the apical impulse, ask the patient to roll onto his left lateral side.
Can you tip over on your left side, please?
That is, into the left lateral decubitus position. Palpate again using the palmar surfaces of several fingers. If you still cannot find the apical impulse, ask the patient to exhale fully and hold his breath for a few seconds.
Exhale fully for me and hold your breath for a few seconds.
Measure the diameter of the impulse in centimeters. Feel for the amplitude of the apical impulse. It is usually small and feels like a gentle tap. With experience, you will learn to feel the apical impulse in a high percentage of patients. However, obesity, a very muscular chest wall, or an increased antero-posterior diameter of the chest may make the apical impulse undetectable. Next, feel for a right ventricular impulse at the lower left sternal border and in the epigastric or subxiphoid area. While keeping one finger in the third interspace, place additional fingertips in the fourth and fifth interspaces. If the patient's chest has an increased antero-posterior diameter, palpate for the right ventricular impulse high in the epigastric area where it may be easier to feel.